To the jurors. Dr. White, good afternoon again, sir.
Thank you very much,
You acknowledge,
Your
sir,
Honor.
you're still under oath and still sworn to tell the truth?
Yes, sir.
Thank you. This is a resumption of direct examination. Mr. Flanagan.
Dr. White, when we left off, we were talking about the I have a hard time with this one, pharmacokinetic and pharmacodynamic variability relating to propofol. Are other drugs variable too?
Yes, most centrally active drugs have similar patterns of variability. And, for example, lorazepam, and I think I have an example that I would like to show and hopefully do a better job of explaining to you what the variability means.
I want to put an article up here.
This is not my paper either, but it is of relevance because it talks about the pharmacokinetics of lorazepam and midazolam for sedation in the intensive care setting.
I want to mark this one. Why, Your Honor?
Triple Yankee.
This paper, what does it involve, Dr. Schaefer? Or Dr. I'm sorry, Dr. White.
I think I'm going to put a name tag.
We were doing that throughout the case, and there obviously is no disrespect intended. We all apologize to everybody who's been misdiagnosed.
I take it as a compliment, actually. So, this is a study looking at comparative population pharmacokinetics. So it's a group of patients receiving either lorazepam or midazolam in the ICU. We frequently give infusions of benzodiazepines, this class of drugs, for patients in the intensive care because, as you've heard, it's a very stimulating environment. Lights are on, beepers are going off, machines are going on, and patients can't sleep. So we often provide sedation with infusions. And one of the techniques that we developed many years ago was to use variable infusions so that during the daylight hours when one of the patients awake, we would give them very low infusions just for purposes of reducing anxiety, so-called anxiolytic effects. And then in the nighttime hours, we would increase the infusion so we could normalize their sleep-wake cycle, so-called circadian rhythm, to allow them to become more normalized. And this was very effective. Initially, we used midazolam infusions, and then subsequently, when propofol became available, we did similar studies with propofol. But this is a study by other investigators, and I think it's just a little simpler way of understanding what I was trying to convey in the previous article. So if you could enhance it a bit. It's a little difficult to read, and it says it's a Xerox copy, but this is the concentration of lorazepam that is predicted, that is based on the model, the pharmacokinetic model that was used. And this is the actual observed or measured concentration. So if there's perfect predictability, that is, if there's a direct correlation, it would be a straight line that would pass right through this point, the 0 point. And what you see is a tremendous degree of scatter. Actually, we call these almost scatter plots, I would say. And so individual patients vary widely in their correlation. And in fact, when they did a regression, so-called regression analysis, which is a mathematical, you can see that the curve that's generated is quite different than the idealized curve. So again, it's just an example of pharmacokinetic variability with lorazepam, which is similar to propofol and other what we call centrally active drugs, that is, drugs that act on the brain.
Let's define that a little bit. The bottom axis, concentration of lorazepam observed. So that's a dynamic.
No, that's kinetic. That's the measured plasma concentration.
Okay, that's what they measured in the blood.
Right, and this was
and
the
it varies between 10 and 1,000 nanograms per milliliter?
Yeah, that's a logarithmic scale, which is sort of a compressed scale. So patients were given widely varying doses, which is very common in the ICU because their requirements are much, their dosage requirements range over a broader range than typically, for example, in the operating room or in a procedural type setting.
So this is an ICU setting here?
Correct.
So you got perfect control of the patient. You know exactly how much you're giving the patient.
Yes.
And lorazepam, that's used for sleep in the ICU?
It is one of the drugs that's used for normalizing the sleep-wake cycle, yes, as well as for its anxiolytic effects, obviously.
So if you were to program a model or do a simulation, which of these lines would you use?
Well, based on these data, you would use this line here that's shown on the graph, because that was a better correlation than the idealized line. You can see there were more data points up here, and when you do a regression, you actually generate a line that provides the least variation about that. So, I'm not very good at describing these things because I'm...
The idealized line, was that the line that was being predicted?
Yes. I mean, that would be predicted if the model perfectly predicted the blood level.
But the squiggly line is what you actually got.
Well, the squiggly line is a better correlation between the measured concentration and the predicted concentration.
So as a result of that, would the investigator modify his modeling technique?
Yeah, frequently investigators do modify their models based on preliminary data, and then they develop models that are more predictive.
Now, the drug propofol, is that an analgesic?
No, propofol is what we call a sedative hypnotic, which means at very low doses you produce sedation or sleepiness, and at high doses you progress continuous. It's a continuum. So you start at very low doses, you may have reduction in anxiety, sleepiness, deeper and deeper sedation or sleepiness, till ultimately patients become unresponsive or maybe responsive to verbal or tactile stimuli. That's what we call deep sedation. And then when they cross over to where they're unconscious and not responsive to noxious or painful stimuli, we refer to that as anesthesia. So it's just this continuum, and sedative hypnotics all have the same continuum from anxiolysis, minimal sedation, to deep sedation, progressing into intravenous anesthesia. Benzodiazepines, propofol, barbiturates all have the same spectrum of activity.
So they're not analgesics.
Analgesics, as we heard earlier, are drugs that either treat or prevent pain.
Would that be lidocaine?
Lidocaine is an analgesic, yes. You can put it on a nerve and it blocks nerve conduction. So it produces desensitization, but it produces either pain relief or more commonly blocks pain.
And a hypnotic is something that puts you to sleep.
Yes, hypnosis is the same as unconsciousness.
And is that why they call propofol milk of amnesia?
Well, amnesia means lack of recall, and most sedative hypnotics have the ability to interfere with recall. The benzodiazepines have a more prominent amnestic effect. That is, with benzodiazepines, patients receiving low doses, which cause minimal sleepiness or sedation, may not recall things. They have amnesia. That means inability to recall. With propofol, they have to be much more sedated to experience amnesia, but they do have this. It does have the same ability to produce amnesia. It just takes a larger amount.
So propofol doesn't deaden anything; it just puts you to sleep.
I don't like the term deaden. We would say cause hyposensitization or numbness is a better word.
Okay. So how is it that they can use propofol for surgery when it doesn't eliminate the pain?
Well, you need to use other drugs and techniques. For example, frequently when we use propofol for sedation, we combine it with local anesthesia. The surgeon or the anesthesiologist will inject local anesthetic at the incision site, or we block nerves. Like, for example, if you're doing surgery on a hand, you might block the nerve someplace in the arm, so it's numb. And then you use the propofol, if you will, to provide a sleep-like state. Often patients are awake or arousable. It depends on patients' desire, whether they desire minimal sedation, some even no sedation. They may be awake. If they're not worried about what's happening in the operating room. They may be very comfortable being minimally sedated, which means they're actually conversant, and other patients want to have deeper sedation. That is, they don't want to be awake and aware of everything that's going on in the operating room. And some patients want deep sedation, which means they're essentially sleeping unless I shake them or squeeze something or cause some discomfort, then they'll arouse.
Now, you've done some studies on MAC sedation, haven't you?
I've done some of the original work. Some people call me the father of MAC, whatever that means.
I'll just call you Big Mac.
No, Big Mac is my professor. That's Dr. Eager, who has a different terminology for MAC. It's minimum anesthetic concentration, but we refer to it as monitored anesthesia care.
Monitored anesthesia care. What exactly is that?
Well, monitored anesthesia care is a term that's commonly used for anesthesia services that relate to monitoring patients, of course, and providing sedation analgesia for minor procedures or superficial surgical procedures. Typically, patients receive local anesthesia, but in some cases they receive no local anesthesia and may just receive small doses of narcotic analgesics. But the key is the ability to provide for patient comfort with a sedative medication like propofol.
So are you using sub-hypnotic levels of propofol for MAC care?
Yes. Monitored anesthesia care, by definition, is sub-hypnotic because once you cross over into the hypnotic realm, you're entering general anesthesia. Although there is a transition, as I suggested earlier, which we call deep sedation. But for the most part, with monitored anesthesia care, we try to stay on the sedation side of that line, if you will.
So propofol has a full range. You can go from extremely deep sedation to just minimal sedation?
To actually no sedation, to just anxiolysis, if you will. I mean, that is reduction in anxiety.
Did you do a study on MAC sedation? That's while you were at Stanford?
Well, in 1987, I was developing techniques for so-called monitored anesthesia care using the available IV anesthetics, methotrexate, etomidate, midazolam, and none were really controllable. That is, I couldn't control the level of sedation as ideal as I desired. And having worked with propofol, I said, it's an amazingly controllable drug. And I thought this could be the best possible agent for use during monitored anesthesia care. So I approached the company in 1997 about exploring this possibility.
87?
87. I'm sorry. I'm having trouble with
That's
the years.
okay. I won't call you Dr. Schaefer. You just get your years right.
Okay. I guess we're even, huh? So it was in 1987, shortly after we finished the earlier study that I discussed. I went to the company and said, I've got this group. I think it's a great idea. And they got back to me and said, we appreciate your enthusiasm. We appreciate the fact you've done really good research, which has been instrumental in the drug sort of being on the accelerated path to FDA approval. But you have to understand that we are developing this drug for induction of anesthesia. We want to displace pentothal, which was the major drug, and possibly develop it for maintenance of anesthesia, general anesthesia. And they thought the use for sedation was not going to be an important use for this drug.
So they weren't interested in your MAC study. Is that true?
Well, not initially, actually. I discussed it at a meeting in the launch meeting just before the drug was approved by the FDA. I actually made a suggestion before a large audience of my academic peers and chairmen and said that I predict by the end of the century you will actually sell more of this drug for sedation than for general anesthesia. And I have to tell you, I didn't intend for it to happen, but I got a nice laugh from almost everybody in the room. But the company said that because you've done good work, we will not sponsor a study directly, but we will give you an educational grant, was not a great large grant, but a small one. If you will petition the FDA to perform an investigator-initiated study to look at subhypnotic doses of propofol for sedation during moderate anesthesia care. And I went ahead and got what's called an investigator IND, so it's my study, my responsibility. They provided me with the drug, and I compared propofol sedation to midazolam sedation, because that was the, quote, gold standard at the time.
So at the time that you were doing this work, am I correct in assuming that propofol had not been cleared by the FDA for use?
Correct. That's why I had to get an investigator initiated IND to perform the study.
In doing this study at the time, would you consider the use of propofol for conscious sedation and off-label use?
Well, of course, it was off-label. The label was just being developed, but the label was for induction and maintenance of general anesthesia. There was no indication for max sedation until, as Dr. Schaefer explained, he worked with a company on developing the new package insert in 1991, I believe it was.
So they had a previous package insert that was used, where propofol was used for anesthesia only.
Yeah, that was the package insert that was available when the drug was approved in 1989.
Package insert transition to include other uses?
Well, around, I believe, 1991 or 92 is when the company AstraZeneca submitted data to the FDA asking for approval for the indication of max sedation, as we heard from Dr. Schaefer, and for sedation in the intensive care unit.
Where did they get this data?
Well, they called me in 1990 and said, would I be willing to provide my data to them to use in developing this new indication? And I guess I was naive. I should have got a patent, but I didn't. And I turned over the data because they were gracious enough to give me some support for my research. And interestingly, they asked me if I would agree to allowing Dr. Schaefer to analyze this data on their behalf. And of course, as a colleague, and I said, sure. I mean, Dr. Schaefer's welcome to do that analysis, and that led to a change in the package insert.
For what purpose did Dr. Schaefer analyze your data?
Well, the company wanted to develop dosing guidelines, and he used my actual patient data as the basis for generating the guidelines that have come out in the package insert.
So Dr. Schaefer basically did the math based upon your clinical data.
Well, he did a mathematical analysis, yes.
And we've used the term off-label. I'm not sure everybody understands what off-label. Does that mean it's illegal? If it's
No, physicians often use drugs off-label. It just means you're using an approved drug for a disease process or a disorder that isn't currently indicated in the package insert. Package inserts are generated by pharmaceutical companies working with the FDA. And if they haven't submitted data to support an indication, for example, max sedation, even though we had done studies, demonstrated that it was safe and effective, until the company submits the data to the FDA, its use in that capacity is considered, quote-unquote, off-label.
To make it on-label, it has to be approved by the FDA?
Correct.
So
in terms of dosing, in terms of indication, and type of treatment.
And then when the FDA approves it, it's on the label, and then it's used pursuant to those requirements, and that's considered on-label use?
Correct.
Would propofol's use for sleep be considered off-label?
Absolutely. For sleep, if you mean sleep apart from anesthesia or a procedure, surgery or a procedure, certainly for sleep, I guess I have to modify my answer, if I may. When you say sleep in an ICU setting, that certainly is on label. But if you're talking about sleep, as we are in this case, where it's outside the hospital or outside a surgery center, that would be off-label, yes.
Well, would it be off-label for a gastroenterologist to use it in his office, would it, for doing a colonoscopy?
No.
And that would be considered moderate sedation or conscious sedation?
It's usually considered minimal to moderate sedation.
Now, with respect to sleep, there's been a recent study in which propofol was investigated for sleep purposes. Are you aware of that study?
Yes, a study by Zhu and colleagues.
Dr. Schaefer didn't think too much of that study, but what do you think?
Actually, I thought it was a very interesting study. It had a control group. It had a period of treatment for, I think, 5 days, and then follow-up for up to 6 months. They did very careful testing. I think Dr. Schaefer's problems with the paper, as we discussed recently, relate to the fact that there was some critical information missing. For example, the investigators talked about the solution that they used, namely 3 milligrams per milliliter of propofol, but they neglected to mention the infusion rate. They gave a pump for 2 hours. So there was information that's obviously critical that was missing, but my take on the paper was a lot different than Dr. Schaefer's, because I believe that in the review process you can obtain that kind of missing information from the investigators. And I think it was a very interesting study in terms of outcome. They showed that using propofol in this way was safe and effective for normalizing disturbed sleep in patients who had chronic intractable insomnia. And certainly it's not a definitive study, but as a first study, I thought it was quite interesting, and so I would have a different take. And I think it would be unfortunate if that paper was not, if the authors of that paper were not given an opportunity to at least have their paper reviewed by experts in the field.
Now, oftentimes are papers written and then subjected to peer review?
All the time.
I mean, is this before or after publication that the peer review takes place?
The peer review is before they're considered for publication. And as I said, once they undergo peer review, as an author, we get back critique sheets, very detailed points that the reviewers want us to address. Sometimes they just reject your paper. They think that you cannot respond adequately to the criticisms, but often the paper is just modified and we resubmit it and it's re-reviewed, and if we do an adequate job of addressing the concerns, then it can be considered for publication. Presently, papers typically undergo 2, 3, or 4 reviews before they're accepted, so it's a lengthy process.
So even the papers that you've published on propofol, they've been subjected to peer review before they're published?
Yeah, I mean, the paper that I just discussed, which I consider a very important paper because of max sedation, which is the current practice. I mean, it literally changed the practice in anesthesia, was rejected by both anesthesiology and anesthesia analgesia. And another paper that Dr. Schaefer referred to repeatedly in all his modeling, the paper by my former fellow Da-Woo Kim from South Korea, looking at the level of propofol that would produce apnea. You probably remember that. So of his models, that paper was similarly rejected by anesthesia and analgesia.
Well, these papers eventually got published, didn't they?
Yes. We send them to other journals, sometimes what's considered a lesser journal. I don't necessarily consider that the case. I think they're still important journals. But there is a pecking order with respect to the journals based on what's called their impact factor. And the impact factor is how often the articles that are published in a journal are cited by other authors and in other journals. So it's something that's very important.
This max sedation study that you did, that was rejected by anesthesia and analgesia?
Yes.
but it got published.
Yes.
Right. And Dr. Schaefer has referred to it in this particular case. Is he not?
Well, sort of indirectly. He used the data in that to develop the package insert for AstraZeneca or help or work with them in developing it. I don't think he specifically mentioned the paper, though, in his discussion.
And the second paper you referred to is rejected for publication by Kim. That paper's been referred to in this case?
Yeah, that's the paper by Dr. Kim and his colleagues has appeared on several of the diagraphs that Dr. Schaefer has shown to illustrate his models.
Well, you said Dr. Kim and his colleagues. Weren't you involved in that too?
Well, I'm one of his colleagues. I'm his mentor. But the study was conducted in Seoul, South Korea, and I don't want to take credit for work where I was not a PI. I was a contributing author, but Dr. Kim deserves credit for the publication.
Now, are you familiar with the levels of propofol that were achieved in this particular case?
Are you referring
read the toxicology report?
Yes, I've read the toxicology report, yes.
And you're familiar with the level of propofol, the levels of the razepam?
Yes, in the various specimens, I might need to have a refresher if you're asking me to recall them from the top of my head.
Are you familiar with the concept of combining drugs?
Yeah, combining drugs I think was referred to by one of the other experts as polypharmacy.
Now, polypharmacy, the use of that term, is that a bad term?
Well, in anesthesia, it's what we do every day. We're polypharmacists. We combine drugs to achieve better effect with less medication, because drugs, when they're combined, can have additive or even synergistic effects. And in that way, we try to eliminate the side effects from any one drug by giving lower doses of several drugs. And the challenge is to make sure you don't have adverse interactions. But for example, in the area of pain management, we combine opioids and non-opioid drugs to reduce opiate-related side effects.
So the mere fact that you're using more than one drug at a time, that's not necessarily poor medicine.
I think it's the best medicine if you choose the appropriate drugs to combine and do them in the appropriate doses.
And with respect to propofol itself, is it commonly combined with other drugs in its use?
Well, one of the follow-up studies that we did for max sedation, published a few years later, we actually demonstrated the benefit of giving small doses of midazolam before propofol. I sort of called it for pre-medication or for induction of sedation. And that midazolam propofol technique has become sort of the standard technique for MAC sedation.
Now, in reviewing the facts of this case, you've familiarized yourself with Dr. Schaefer's report, I take it?
Yes, he actually had 2 reports, as I recall.
And with respect to his modeling, as it relates to the statements of Dr. Murray, are you familiar with those?
If you could show me exactly what you're referring to. It was a lengthy letter. He drew a number of graphs, if that's what you're referring to.
In his preparation of graphs, I want to show you.
Could you show me the axis? Oh, thank you. I need to tell Dr. Schaefer he needs to learn how to spell plasma, because I noticed it was also misspelled in the
Objection,
FDA.
this is not Dr. Schaefer's graph, which was made by some other company as illustrated on the bottom of the exhibit.
The objection is saying it's also non-responsive. So the partial answer stricken disregard. Can we have clarity, because we're showing the graph? Has this been identified before?
Well, you know, I think that graph, exact graph, is in evidence.
I think it's in the letter, Schaefer's.
This is a modified graph.
How is it modified? Do you want to mark it as your own exhibit?
Yeah, I guess I'll mark
Triple
it
Z.
down, but I think that has been shown.
You've got to let me know. I don't know right now.
I think it's in his assessment of the case, as I recall.
Why don't I mark this temporarily, Your Honor, and I'll substitute it for Dr. Schaefer's actual graph. This is basically a copy of.
Why would I would object? Why are we marking it? Why don't we just find the actual graph?
I think that would help if we can. Can the people be of some assistance if it was marked previously, please?
Here's a copy of Dr. Schaefer's report.
Well, I know, but is there an exhibit attached?
We could make this exhibit, would it be ZZ?
Well, Mr. Walden, unless you want to reference something specifically.
Right. I'll be happy to help. There's hundreds of exhibits.
Yes, there are. You want to take a moment? The counsel would, please.
I've got up here a copy of the graph. It's just smaller. It's not as pretty, but it's out of Dr. Schaefer's report.
Well, I think you can mark it as your own, even though the people may have reference to something else. So this is triple Zulu.
Yeah, we've got that graph previously marked as CC.
All right, so I'm going to forget about the new marking. Charlie, Charlie.
Do you recognize that as being a copy of the graph in Dr. Schaefer's report?
Yes, I do.
What does that graph indicate in terms of Dr. Murray's statement?
Well, it shows the plasma lorazepam concentration. This was the concentration that was measured in the femoral vein at autopsy. It has two lines, one above and below, talking about responsiveness to painful stimulus and non-responsiveness to painful stimulus. And I'm not really sure what that means when you're talking about lorazepam, because it's not an analgesic, that it doesn't have pain relieving or preventing properties. But basically what it illustrates is the two time points at which Dr. Murray administered bolus doses of 2 milligrams of lorazepam, here at 2 a.m. and then again at 5 a.m. And it shows the modeled, or if you will, idealized blood concentration curves, which might result from 2 milligram doses, with the caveat that that's an average or mean value. In the case of Mr. Jackson, it could have been different.
Did Dr. Schaefer also diagram the midazolam levels?
Yes, I believe so. At least I remember in the letter or the declaration that he submitted.
I need just a minute. I thought I had that one set out.
Yeah, I want to ask for clarification. I show CC as a photo of a plastic bag.
3 Cs.
Is it triple C?
Yes, that's true.
Triple C, please. Thank you.
Your Honor, perhaps this would be a good time to take the afternoon break so I don't waste...
And for the whole evening, too.
Okay.
May I see counsel, please? Recess and adjournment at this time. Dr. White, thank you for your testimony. Rather than keep you up here right now, I'm going to excuse you and thank you and ask you to follow all the admonitions. Please come back tomorrow morning at 8:45. Thank you. Ladies and gentlemen, I will deliver to you these admonitions as I do every day. Please don't discuss this case among yourselves or with anyone else, or form or express any opinions about the case until it's submitted finally to you. Do not visit any scene or location that may have been referenced, mentioned, or involved in this case. Don't perform any experiments or on your own or through another person conduct any independent research or investigation on any topics, subjects, or persons mentioned or involved in the case. Do not read, listen to, or watch any television or radio programs, newspaper or magazine articles, or the Internet regarding any of these topics, subjects, or persons. Don't access any Internet websites, including but not limited to any search engine sites such as Google, Ask, or Bing, or social network sites, including but not limited to Facebook or MySpace, or text or tweet anything about the case, or access any blogs or post any messages on any blogs or any other sites regarding any aspects of this case. Have no contact whatsoever with the defendant, the attorneys, the witnesses, or spectators. If anybody contacts you or tries to contact you with regard to this case in order to discuss it, immediately cease any such contact or conversation. And if anybody tries to contact you with regard to later developments in this case, in an effort to have you at a later point in time contact or communicate with any person or organization about the case, immediately rebuff any such invitation and notify us of such an encounter. Do all of you, again, continue to understand and assure and promise us you will follow the written admonitions which I provided to you at the beginning of the case, as well as these continuing verbal admonitions? All indicate in the affirmative. Thank you. Ladies and gentlemen, we're going to ask you to join us at 8:45 tomorrow morning. And again, with my continued thanks, have a good evening. We'll see you tomorrow morning at 8:45. Good night.